Hello, this is Stephen Bonsib coming to you once again from Arkana Laboratories in Little Rock, Arkansas. This is the sixth part of my six-part series that led off with a discussion, a brief overview of renal embryology. This was followed by several talks related to congenital anomalies of the kidney and urinary tract and ciliopathies. I will conclude this series with a talk today that I've entitled Miscellaneous Cystic and Developmental Abnormalities. Although it's called miscellaneous, it really includes some important and common disorders as well as a couple rare disorders. I will lead off with localized cystic kidney disease, which is often also called isolated cystic kidney disease. It's a very rare disorder. It's non-familial, non-progressive, and its etiology is unknown. It shows a marked male predominance in incidence up to 80 to 90% and is usually encountered as an incidental finding and will most often present as a nephrectomy specimen in the surgical pathology lab. As the name indicates, localized, it is not associated with extrarenal malformations or any evidence of lower urinary tract disease. It's mostly unilateral, and it may be localized or diffuse, and when localized, it's non-encapsulated. Radiographically, if the lesion is localized, it's often mistaken for a cystic neoplasm, such as mixed epithelial and stromal tumor, cystic nephroma, or a cystic renal cell carcinoma. If diffuse, it's often mistaken for multicystic dysplasia, because that lesion is a far more common finding. Microscopically, it bears some superficial resemblance to autosomal dominant polycystic kidney disease in the sense that cysts are separated by normal to atrophic parenchyma, and I'll illustrate all these features in a moment. Here I have three gross photographs providing the range of cystic alteration you can see in localized cystic kidney disease. In the upper left, we have a kidney which is diffusely replaced by cyst. This is the least common presentation. And if I were to encounter this lesion in the frozen section or gross room, I would usually assume that it's an example of multicystic dysplasia. It is much smaller than autosomal dominant polycystic kidney disease, and in contrast to cystic dysplasia, does not have lower urinary tract abnormalities. If we move to the upper right, we can see a kidney that shows more limited involvement, although still extensive, with some portions of the kidney completely normal, but approximately 2/3 of the kidney are transformed into cystic mass, and you'll notice there's no encapsulation of the mass. Finally, at the bottom image shows a very small lesion of localized cystic kidney disease. Now, microscopically at low power, we can see the lesion again is composed of numerous cysts. The cyst lining is very inconspicuous and difficult to see at this magnification, but you'll notice between the cysts there are areas in which there is seemingly normal renal parenchyma and other areas in which there is atrophic or fibrotic parenchyma, similar to what one would see in autosomal dominant polycystic kidney disease. If we look at the cyst lining at higher power, it has a quite distinctive appearance. It's lined by a hobnail to low cuboidal epithelium, and when immunohistochemical stains are performed, it marks as a distal tubule or collecting duct phenotype. So it would be positive for high molecular weight cytokeratins, cytokeratin 7, and epithelial membrane antigen. Although usually encountered in a nephrectomy specimen, occasionally it will show up on a kidney biopsy. And here's one such case I encountered several years ago, in which we can see the needle core consists solely of cysts and cyst septae. But if we look at the cyst lining cells, again, they show that very characteristic uniform hobnail to low-cuboidal epithelium. Next, I'd like to discuss a very important entity, namely acquired cystic kidney disease. Simon, in 1847, is credited with the first description of this lesion, and he described the presence of cysts in small contracted kidneys, in which the contracted kidneys showed diffuse nephron sclerosis. There was no evidence of infection, lower urinary tract obstruction, or lower urinary tract abnormalities. And I've extracted a quote from his publication, which I will read, and it goes as follows. I shall endeavor to fix attention on changes that run a slow and insidious progress during life. Vesicles are substituted for the normal tubularity of the gland. Will lead me to explain the origin of those large cysts, so well known in the dead house. I put this quote in here because the dead house is rather an amusing reference to the autopsy suite, but also it indicates that the cysts were known prior to his publication, since he indicates they were well known. On the right side of this slide, we can see drawings taken from his 1847 publication. They're of low quality and low detail, but I think here on the upper right you can see the external surface showing numerous cysts, a cross-sectional surface again showing a diffuse variably sized cyst, and here at the bottom we can see what appear to be tubules that are ectatic or have a very nodular profile, as well as glomerular cysts. And cysts do form in all segments of the nephron and collecting duct in this disease. Now, this disease was essentially rediscovered 130 years after the Simon publication. Back in 1977, Dunhill et al. Noted the frequent occurrence in end-stage renal disease, the presence of diffuse cysts. He performed an autopsy study of 30 patients on long-term hemodialysis and noted that 14 of these 30 patients showed diffuse cystic transformation of their small contracted kidney. And this is an image here on the left, a photograph from that publication showing the diffuse cyst formation that vary in size. More notably, he noted that in the 14 cases with cysts, 6 of those cases contained renal cell carcinomas, and in 5 of those 6 cases, the renal cell carcinomas were multifocal. In the photograph on the left, we can see a renal cell carcinoma here, which has a solid and a hemorrhagic component, and there was a second renal cell carcinoma down here at the bottom of this photograph. Some basic facts about acquired cystic kidney disease. The definition is 3 or more cysts in one or both kidneys, but no cysts should be present prior to the onset of end-stage renal disease. Furthermore, there should be no history of cystic kidney disease. Acquired cystic kidney disease may occur prior to dialysis and is present in about 90% of patients who have been on dialysis by 10 years. Since it occurs prior to development of dialysis in some patients, it may be encountered on renal biopsy. Acquired cystic kidney disease is more common in blacks than in Caucasian, more common in males and females, and this is shown here in this graph on the right, where here we can see the cyst enlargement in males and females that is occurring over a 20-year period. And notice this cyst enlargement, which cyst volume is a surrogate marker for cyst size and number, the cyst formation occurs more prominently, more rapidly in males than in females. Renal transplantation may diminish the severity of acquired cystic kidney disease in some patients. The main clinical importance of acquired cystic kidney disease is its relationship to renal neoplasia. Patients with acquired cystic disease are estimated to have a 50 to times greater risk for renal cell carcinoma compared to the sporadic cases occurring in the population. Renal carcinoma is more common in men's and more common in blacks. Fortunately, the renal cell carcinomas tend to be smaller and lower stage and less aggressive than their sporadic counterpart. Of importance, though, is to realize that 1/3 of the renal cell carcinomas that occur in end-stage kidney disease occur in the absence of acquired cystic kidney disease. Furthermore, it's important to keep in mind that acquired cystic kidney disease also develops in children. If we look at this graph here on the left, this was a large study of pediatric patients on dialysis. We can see here at the bottom duration of dialysis and number of patients with cyst formation. The white bars indicate no cysts, the hatched bars indicate the presence of one cyst, and the black bars indicate the presence of acquired cystic kidney disease. And you can see, similar to adults, by the time an individual is on dialysis for 9 or 10 years, almost every patient will have acquired cystic kidney disease. Furthermore, they similarly have an enhanced risk for renal cell carcinoma. This case report by Chan and Warrady, published in 2018, shows a gross photograph of a cystic renal cell carcinoma. Here we have a cyst which has formed and has a mural nodule of papillary renal cell carcinoma. So both acquired cystic kidney disease and renal neoplasm do occur in children, so some vigilance is required. The pathologic features of acquired cystic kidney disease are listed here. The kidney tends to be small to normal size, even though diffusely cystic. This is important because grossly it bears some resemblance to autosomal dominant polycystic kidney disease. However, in that disease, the kidneys are going to be markedly enlarged. Similar to autosomal dominant PKD, cysts develop in both cortex and medulla and in all tubular segments of the nephron and collecting duct. Most cysts have an attenuated cell lining. However, occasional cysts have what are called atypical cell lining, and these likely represent a precursor of renal cell carcinoma. They are characterized by cell stratification, cell enlargement, and nuclear atypia, and their cytology and immunophenotype is similar to renal cell carcinomas that may also occur in that same specimen. Furthermore, they have cytogenetic abnormalities such as 3p deletion and chromosomal gains, which support the neoplastic nature and their potential as renal cell carcinoma precursors. Although many tumor types occur in end-stage kidneys and in end-stage kidneys with acquired cystic kidney disease, two benign tumors, papillary adenomas and clear cell papillary renal cell tumor, are the most common benign tumors, and acquired cystic kidney disease is the most common renal cell carcinoma, and it is unique to development in the presence of acquired cystic kidney disease. That said, many other types of renal cell carcinoma also occur. Here are 3 gross examples of acquired cystic kidney disease, indicating the range of severity that one can encounter. In the upper left, we have a number of cysts, more localized here in this pole. The cysts are both medullary and cortical, although much of the renal parenchyma itself is non-cystic. Here at the bottom right and in the upper left, we have increasing degrees of cyst formation, and particularly the kidney in the upper right shows a diffuse cystic transformation and resembles a miniature version of autosomal dominant PKD. Acquired cystic kidney disease, of course, develops within a background of advanced chronic kidney disease, and this is shown in these 2 cases here, where we have diffuse nephron sclerosis occurring in both cases, and then we can see portions of a cyst in the left image and a cyst in the right image, as well as a couple smaller cysts. Here's another example of acquired cystic kidney disease in which we have variably sized cysts occurring in the background of diffuse nephron sclerosis. And if we can look at higher magnifications in these two images on the right, this would be indistinguishable from the appearance of autosomal dominant PKD, although occurring in the context of initial CKD with subsequent cystic transformation. One feature that is common in acquired cystic kidney disease, which is not usually seen in autosomal dominant polycystic kidney disease, is the presence of numerous calcium oxalate crystals. We can see some crystals here on this left-hand image, which are even more prominently visible under polarization here on the right. Now, acquired cystic kidney disease doesn't develop prior to the onset of end-stage renal disease. So in patients biopsied with CKD4 or CKD5, we will see this disease not infrequently present. The example shown here shows several small cysts. We can see a cluster of 3 right here, a small cyst up here. Again, these cysts have a very inconspicuous attenuated cell lining. These cysts are quite small, probably 1 millimeter or less, which is below the ultrasound threshold of about 2 millimeters, which means we can see acquired cystic kidney disease on biopsy prior to its radiographic demonstration. This is another example of acquired cystic kidney disease. If we look at these two cores here on the left, that we see quite a bit of chronic change. This third core has a little bit less chronicity present. And if we look at the edge of these cores, sometimes the cyst can be inconspicuous. And notice the edge of both of these cores, when examined at higher power, show a cell lining indicate the presence of a large cyst. And if we look at the background, we can see tubular ectasia and microcyst formation as these other nephron portions are beginning to undergo cystic alteration. This is an example of more advanced acquired cystic kidney disease on biopsy. Here in the trichrome stain on the left, we can see diffuse tubulointerstitial and glomerular scarring. And we have numerous cysts that are formed. They range from just ectatic tubules to microcysts to cysts that are probably beginning to meet the threshold for ultrasound demonstration. The cyst in acquired cystic kidney disease will often have somewhat dirty contents like we see in autosomal dominant PKD. You can have proteinaceous debris, calcification, and sometimes hemorrhage. I previously indicated that some cysts in acquired cystic kidney disease appear neoplastic, so-called atypical cysts. If this is an example here in a nephrectomy on the left side, we can see at low power, again, chronic glomerular and tubulointerstitial scarring, numerous cyst formation. The cyst lining, most of the cyst lining is inconspicuous, but if we look at this area right here and examine it at higher power, we can see marked cytologic atypia. There's nuclear enlargement, prominent nucleoli, and there's also cell stratification. So these are atypical cysts and indicate a neoplastic diathesis in this kidney. These are additional examples of atypical cysts on renal biopsy. The cysts may vary a lot in their cytologic appearance. They can be composed of eosinophilic cells. They can be composed of clear cells or cells with foamy cytoplasm, and they can show architectural complexity. These two cysts, atypical cysts on the left, may simply be atypical cysts. However, one can never be certain when you see an atypical cyst if they're not part of a cystic neoplasm. Therefore, imaging studies, MRI or CT examination, are important to be performed to determine if a mass is present. If we look at the atypical cysts on the right side and in the middle figure, we can see much greater complexity with prominent papillary formation and pericystic fibrosis. And these atypical cysts, I would be quite concerned, might be part of a mass lesion and an actual renal cell carcinoma. But again, one has to defer to imaging to make that determination. In the absence of detection of a mass, then these are clinically insignificant, although again, they indicate a neoplastic diathesis in these kidneys. This is a nice table from a recent publication in 2022, which shows the different types of renal tumors present in patients with end-stage renal disease or a combination of end-stage renal disease and acquired cystic kidney disease compared to cases occurring sporadically. And you'll notice that acquired cystic kidney disease associated renal cell carcinoma only occurs in the presence of acquired cystic kidney disease. Conversely, clear cell papillary renal cell carcinoma, which is referred to now as clear cell papillary renal cell tumor because those tumors have not been shown to develop metastatic disease, so now it's regarded as a benign entity. This tumor is very common in end-stage kidney disease as well as acquired cystic kidney disease, but is very rare in the sporadic sense. Sporadic tumors, of course, are predominantly clear cell renal cell carcinoma, which are correspondingly less frequent in end-stage renal disease and acquired cystic kidney disease. Nonetheless, in both of these clinical contexts, a variety of tumor cell types are possible. These are examples of renal neoplasms occurring in acquired cystic kidney disease. Here in the upper left, we have diffuse cystic alteration, and we have two clear cell renal cell carcinomas, one right here and a second one here at the top. In the middle image at the bottom, we have less severe cystic kidney disease, and we have multiple papillary adenomas. Here is one that's probably about 5 or 6 centimeters or 5 or 6 millimeters in size, with a couple millimeter size ones visible as well. Conversely, here's an example of an end-stage kidney without acquired cystic kidney disease in which a papillary renal cell carcinoma has developed. These are some microscopic images of a millimeter-sized papillary adenoma and somewhat larger papillary adenomas occurring in end-stage kidneys. And this is a nice example of the clear cell papillary renal cell tumor. So these are the benign neoplasms that are common in end-stage kidneys and acquired cystic kidney disease. Conversely, here's a single image of acquired cystic kidney disease associated renal cell carcinoma. And this neoplasm is notable for the presence of numerous calcium oxalate crystals, which we can see here throughout the neoplasm. This crystal formation is unique to this neoplasm. In this table, I provided a comparison and contrast between autosomal dominant PKD and acquired cystic kidney disease, simply because on gross examination and microscopic examination, they have some similarities. The main difference between them are listed in the first two lines, namely acquired cystic kidney disease. The kidneys are small to normal in size. Conversely, in autosomal dominant PKD, the kidneys are very enlarged. Cyst formation occurs early on in autosomal dominant PKD, whereas it only occurs at the latter stages of advanced CKD and acquired cystic kidney disease. Autosomal dominant PKD, of course, has a family history. Atypical cysts are limited to acquired cystic kidney disease, although autosomal dominant PKD does have the distinctly benign papillations that I demonstrated in the earlier talks about that entity. Calcium oxalate crystals are largely present only in acquired cystic kidney disease as well as renal neoplasms. Now I'd like to move on to lithium-associated kidney disease. Lithium has many renal consequences, both functional and morphologic. The most common abnormality is the functional abnormality of nephrogenic diabetes insipidus. This is present in 20 to 40% of patients on lithium, and it's due to dysregulation of the aquaporin 2 expression in the renal collecting ducts. And they become desensitized to antidiuretic hormones, so patients present with polyuria and polydipsia. There are a variety of morphologic abnormalities associated with lithium, particularly long-term lithium treatment. The most common abnormality is a chronic tubular interstitial nephropathy, and it's the most common finding on kidney biopsy. It can progress to end-stage renal disease, but fortunately this complication is infrequent, occurring in 1 to 2% of patients, and usually does not occur until after prolonged therapy, namely 20 years or more. Rarely a glomerular lesion, focal segmental glomerulosclerosis, may develop, and of course these patients present with marked proteinuria. A couple of reports have indicated what appears to be an increased risk for a variety of renal tumors, both benign and malignant, in patients on long-term therapy. In this first article by Zaidan, 14 of 170 consecutive patients on long-term lithium therapy had renal tumors. They had seven renal carcinomas and 7 benign tumors, both of these of a variety of types, as you can see listed here. Similarly, Ruckmacher, in a study of 50 patients on long-term lithium, identified 6 patients with tumors he reported to be of collecting duct origin, namely collecting duct carcinomas and oncocytomas. And one of the more important things that lithium is associated with a variety of morphologic abnormalities. The most common is a chronic tubulointerstitial nephropathy. It's the most common biopsy finding. Fortunately, this abnormality only rarely progresses to end-stage renal disease, which occurs in about 1 to 2% of patients and usually is delayed until about 20 years or more of therapy. Rarely a glomerular lesion, focal segmental glomerulosclerosis, may develop in lithium-treated patients, and of course these patients present with marked proteinuria. Renal tumors have also been described, both benign and malignant, in 2 fairly large studies of patients on long-term lithium therapy. Notice in this publication, 14 of 170 patients. In the second publication, 6 of 50 patients developed a variety of benign and malignant tumors. However, we want to focus in this talk on renal cyst formation. This is an example of lithium-associated chronic tubulointerstitial nephropathy. This is from a nice publication out of Columbia, first authored by Dr. Markowitz, published in 2000, and it shows the chronic tubulointerstitial nephropathy, but also shows the lithium-associated cysts. We can see 2 here on the left, or 3 on the left, and multiple cysts on the right. Lithium can produce several associated cystic lesions in the kidney. The most common is simply multiple renal cysts, and this occurs in about 40 to 60% of biopsy patients. Occasionally, numerous cysts will form in patients on lithium, and a cystic kidney disease may develop. And rarely the cysts may cluster in a portion of the kidney and simulate a cystic neoplasm. The cysts in lithium-associated cystic kidney have a very distinctive appearance. They're usually small, usually 1 to 2 millimeters in size. And these are nicely demonstrated in the two images on right. Notice the cysts are lined by a low cuboidal epithelium. The cysts are confined to the collecting ducts, thus they are present both in cortex and medulla. The cysts themselves have no cytologic atypia, and although renal neoplasms may be increased in incidence in patients on lithium, the lithium cysts themselves show no cytologic atypia or evidence of them representing a precursor lesion. This is another example of lithium cysts on biopsy. This biopsy was from a 76-year-old female. She had a 20-year history of lithium, presented with a creatinine of 3.1. Her fundamental disease was arterial nephrosclerosis, and we can see a markedly occluded artery here at the top on the left. And there were multiple scattered cysts, and we can see the cysts have the typical low cuboidal collecting duct type lining, so characteristic of lithium cysts. This is an example that could be regarded as a case of lithium-associated cystic kidney disease, although alternatively one could interpret these findings as a patient with chronic tubular interstitial nephropathy that also has numerous lithium cysts. We can see in the cores here on the left that there's significant tubular interstitial scarring with no normal appearing nephrons, and there are multiple cysts present, which we can see at higher magnification here in the middle and right image. And again, the cysts are lined by the very typical low cuboidal collecting duct type epithelium. This is an example of lithium-associated cystic kidney disease. If we look at the gross photograph on the left, we can see numerous cysts replacing all of the renal parenchyma. And here at the upper right portion of this bivalve specimen, we actually have a renal cell carcinoma, which, as we can see here on the far right image, is a clear cell renal cell carcinoma, and the cysts themselves are lined by the characteristic low cuboidal lithium type cyst formation. This is simply an example of a case report of a cluster of cysts that was on imaging studies regarded as a cystic neoplasm. We can see the radiographic evidence of the cystic lesion here. It's a little harder to see in this gross photograph of the bivalve specimen. The kidney itself and other areas, as well as a cystic lesion, was again lined by the typical low cuboidal collecting duct type epithelium. Next, I'd like to move on to the most common renal cyst present in kidneys, the simple cortical cyst. In patients with isolated renal cysts greater than 1 centimeter, whether they're simple cysts or having more complex appearance, are usually defined radiologically and classified according to the Bosniak classification of simple and complex renal cysts. And I have listed here the 1997 formulation, which was formulated based on CT examination of the kidney. More recent formulations have somewhat different criteria for CT versus MI classification of cystic lesions, but I want to just point out in this classification here, simple cortical cysts are comprised of are regarded as a Bosniak class 1 lesion, and they are defined as hairline thin-walled cysts. They have water attenuation signaling because they are simply fluid-filled, and importantly, they have no cyst septa, so they're not complex cysts, and there's no calcification, solid components, and they're non-enhancing lesions. Simple cortical cysts are the most common type of renal cysts. They're more common in men than women, and their incidence increases with age. And this age increase is shown in this graph here in the upper left, where we can see ages listed at the bottom, prevalence of simple cyst formation here on the left, and you can see once an individual achieves an age of around 40 to 50 years of age, the, the, the incidence of a simple cortical cyst begins to increase rapidly. And by individuals over the age of 70, a large fraction of patients will have at least one simple cyst. Simple cysts tend to increase over time, and this is shown in this graph here, where we have age at the bottom, size in millimeters, and you can see in most cases, simple cysts progressively increase with age. Fortunately, most simple cysts are asymptomatic, but in 2 to 4% of patients, symptoms will occur. They are namely flank pain and sometimes hypertension, and this occurs when cysts become very large, in the 6 to 8 centimeters range. In those associated with hypertension in a single cyst, sometimes aspiration of the cyst will lead to resolution of the hypertension. Now, these are some examples of simple cysts. I have 2 gross photographs. The gross photograph on the left shows 6 simple cysts, and in fact, this patient at the time of autopsy was regarded as having autosomal dominant PKD because the contralateral kidney similarly showed multiple simple cysts. However, we can look at these cysts and we can see they have a very thin translucent wall, and most of the renal parenchyma, aside from these large exophytic cysts, is completely normal. In the middle gross photograph, we have another single simple cyst, again showing the very thin translucent cell lining. Curiously enough, in both of these cases, there was an associated clear cell renal cell carcinoma. That said, there is no relationship with neoplasia with renal cysts. The photograph on the far right simply is a nephrectomy specimen in which the subcapsular surface is out here, and we can see a small simple cyst with a very attenuated subcapsular portion, which correlates quite well with the very translucent nature of the cyst we can see in the gross photographs. Simple cysts can appear on renal biopsy. Here's an example of what I regard as 2 simple cysts. This was a biopsy from a 35-year-old female with hematuria. The hematuria was due to thin basement membrane nephropathy. And here we can see a core of tissue in which most of the tissue is non-scarred, and we have small cysts here lined by attenuated epithelium, which I regard as an example of simple cortical cyst formation. Here's another example in which we have an 86-year-old who presented with severe hypertension, creatinine of 2.3. Biopsy showed diabetic glomerulopathy and acute tubular injury. And again, we have multiple small cysts lined by attenuated to low cuboidal epithelium. And I regard these as simple examples of early stage of simple cyst formation. Now, this table compares and contrasts a number of cystic kidney diseases, 3 that I've discussed today, as well as autosomal dominant PKD. And I'll just point out a few highlights. First, the cysts in lithium are very distinctive, lined by the low cuboidal collecting duct epithelium, whereas in most of the cysts in the other 3 conditions are lined by attenuated flattened cells. However, that said, cell stratification and atypical cysts, are limited to acquired cystic kidney disease, while benign papulations are limited to autosomal dominant PKD. Calcium oxalate is particularly prominent in acquired cystic kidney disease. Both autosomal dominant and acquired cystic kidney disease show cyst contents that have a dirty quality, and neoplasms are most important in acquired cystic kidney disease, but also may be of concern in patients on long-term lithium therapy. The final entity I'd like to discuss is also a very rare entity, but it's a very curious entity. It's called renal tubular dysgenesis, and is simply a failure of proximal tubular differentiation. This is a rare disorder, and it's fatal and neonatal in onset, and because it's so rare, its incidence is not really known, particularly since autopsies are not performed very often these days. Mothers present with oligohydramnios, and because of that, the newborns are born with a Potter or oligohydramnios phenotype, which I discussed previously in the discussion of bilateral agenesis or Potter syndrome. Newborns present with severe hypotension and die of respiratory failure, and again, their respiratory failure is due to the presence of oligohydramnios, in which fetal urine is not available to promote proper pulmonary development. Some patients have an associated ossification defect of the skull and present with wide fontanelles. Renal tubular dysgenesis, the causes can be genetic or acquired, but they all hover around the renin-angiotensin system. There are several genetic causes in which there are mutations of one of several proteins in the renal angiotensin system. Conversely, acquired forms of renal tubular dysgenesis are due to inhibition of the renal angiotensin system. And there are rare cases of twin-twin transfusions in which the donor fetus develops renal tubular dysgenesis. Renal tubular dysgenesis is very distinctive in its appearance microscopically. The kidneys show prominent glomerular clustering. The glomerular clustering is due to the fact that the tubular portion of the nephron has a distal tubular phenotype, and distal tubules are smaller in size than proximal tubules. Therefore, the glomeruli cluster and the kidneys grossly are much smaller than normal. And you can see in all three of these images that all of the tubules are small, collecting duct type. We don't have any large renal tubules with prominent pink cytoplasm, characteristic of proximal tubular differentiation. Similarly, on PAS stain, in these two cases, we can see that there's no PAS stain indicating a prominent brush border of proximal tubular differentiation. And this is another case of renal tubular dysgenesis. Again, there's marked glomerular clustering. The tubules between the glomeruli are small and inconspicuous. And although this trichrome stain on the lower right is rather pale, it's simply shown to indicate that there is no interstitial fibrosis. So this is not a regressive change. This is, in fact, a developmental defect. Renal tubular dysgenesis can also be detected in a fetus, although this is admittedly a little more challenging to diagnose. I have two images here. The one on the left is renal tubular dysgenesis, and this is comparing it to normal nephrogenesis on the right. If we look at normal nephrogenesis, we can see by the time we have our first developing well-formed glomerulus, we have a prominent proximal tubular differentiation. Whereas if we look at the image of renal tubular dysgenesis on the left, we can see even after multiple nephron generations with well-formed glomeruli, the tubules in between the glomeruli remain small and inconspicuous, lacking the abundant pink cytoplasm of proximal tubular differentiation. Similarly, electron microscopy in renal tubular dysgenesis, the cells are small and cuboidal. They have relatively modest numbers of organelles, and they lack microvillus brush border, in contrast to a normal proximal tubule here on the right, where we have numerous organelles, many mitochondria, and a very lush microvillus brush border. Well, this concludes my 6-part series that initially provided a brief overview of renal embryology, which was followed by 5 segments that discussed the major developmental renal anomalies and cystic kidney diseases, as well as a number of very infrequent entities. I hope that you found this series both interesting and informative, and also hopefully it will be helpful in your practice of renal pathology or nephrology. As I conclude, I will return to the OrphanNet quote that I shared in the second segment of this series, as shown on this slide. Rare diseases are rare, but rare disease patients are numerous. Although some of the diseases I discussed are encountered in renal biopsy, many others are not, but all represent the renal lineage of a large fraction of dialysis and renal transplant patients. Thus, familiarity with these individually rare conditions is crucial to achieve a thorough understanding of the kidney and its many departures from normal. Thank you.